All right, so think about this. You have a routine 16-week prenatal note. Maybe you put down blood pressure, fundal height, fetal heart tones, and then maybe you just say, patient doing well, return in 4 weeks. Now, under the global model, that note was totally fine. But under 2027, that note may cost you money on your prenatal visit.
Welcome to NatRevMD, a podcast where we share tips on optimizing medical billing and improving practice efficiency so you can have the business of your dreams. I'm your host, Dr. Heather Signorelli, founder of NatRevMD. Let's get started.
So today I've got a guest with us, Maria Reynoso. I'm going to introduce her here in a second. I'm excited to chat with you guys about all the things prenatal visits and really what you guys need to prepare for the upcoming changes for the global notes. All right, so welcome to the show. Thank you for being here, Maria. I appreciate it.
Hi, Heather. Thank you for having me. My name is Maria. I have been in the OBGYN coding world for about 20 years now. And I'm excited to be here and share some of these upcoming changes with you.
Awesome. Thank you. So for the listeners, Maria is a director here at our firm, and she's been with us for several years. And as she mentioned, she is a master at all things OB. I think if you guys were listening to the episode last week, we talked with Amy. This week, we're going to talk with Maria, all of these episodes so that you guys are prepared for the global changes that are coming in January. I want this to be I'm prepping now so that January, it's not a surprise. And so today we're going to talk all the things about prenatal visits because Maria, you see the denials, like you see the stuff that comes back at and what you're having to do in terms of submission for notes. So just before we even get started with questions, like what happens when you get a denial and like notes come and note requests are coming through? Like what does that look like on your end from a team perspective?
So when we get a denial and the notes are not justifying this code that was billed is when we really have to reach out to the provider and do some coding education. And if the note is not there to support, we are not going to get paid on this code. So that's very important for providers to meet with the coders and say, hey, these are the elements that you missed to meet the code that was billed. So if I get a denial, I treat that as a red flag. We may have an issue with the coding. With the documentation per se.
Totally. And do you see do you see denials on the clinic side today too, like your regular E&Ms? Are payers asking for documentation for like an E&M code just as much as you're seeing them ask for documentation for like an op report? Or do they ask do they send more requests on the operation side versus the clinic side?
No, we're definitely seeing medical record requests for E&Ms, especially United Healthcare, Blue Shield. They are checking those medical records to make sure that the documentation meets the code that we build. Either it's whether we build the E&M by itself or with a procedure such as an ultrasound, a biopsy. They're making sure that the E&M that we build was reported separately and documented and not bundled with that ultrasound or biopsy that was performed on the same date of service. So if that wasn't documented separately, then you're going to receive a denial for that.
Got it. And the reason I'm kind of setting the stage here is so we've got these global changes for OB that are coming, right? So in the past, like everything was bundled into the global code. You see a patient for 9 months, drop a global fee at the end. And notes for the clinic piece, were they ever really asked? Or like, was it infrequent to have to send notes? Maybe ultrasound maybe would be a different scenario. But did you see note requests for a prenatal visit prior?
No, very rarely. Maybe when we built like an Antepartum-only code is when they requested a copy of the prenatal flow sheet. But I've never really got requests just for like a prenatal visit. You know, it's only if we're billing Antepartum-only codes. And for whatever reason, they may want to check the record.
Okay, got it. So coming January, here soon to us, that's all changing. So maybe go over just a little bit about what codes are changing, right? The antepartum codes that are getting deleted, the OB codes that are getting deleted, just high level. So folks who are listening can remind themselves what's going on. Again, this is our third episode, but I think folks are still trying to soak it all in.
Of course. So beginning January 1st, 2027, our traditional OB global package is being eliminated. Prenatal visits generally being will be billed with E&M codes, meaning each prenatal visit encounter must stand on its own documentation rather than being being bundled into a global code. Our antepartum-only codes, so 59425, 59426 will be deleted. The global codes 59400, the 59510 for your C-sections will be deleted. So no bundling of prenatal visits in any form, which means that in 2027, every prenatal encounter will be billed as an E-code. Your new patients 99202 through 99205, established 99211 through 99215. You will apply a modifier TH on all of them. Framework for telemedicine, telehealth visits. The code has to reflect what actually happened at that specific encounter. So it cannot default to one code for every patient every time. The prenatal visit has always felt like a category, but starting 2027, it's a billable event every single time. So that's how we have to view it moving forward.
And that's going to be, I think this is my fear. I mean, obviously we're going to have to document the labor management and the delivery. So obviously those, the same principle applies with regards to being very detailed when it comes to your notes, because now it's standing alone.
Yes.
And if they request, medical records, they can say, well, I just want, September 1st's medical record. And that note, if you build a 99215, has to have all the elements of a 992, a level 5, which is different than what they've traditionally been, documenting for a prenatal visit.
Yes. I mean, if I can tell providers, your documentation is going to have to clearly support your problems addressed, your data that you reviewed. So now you have to say labs reviewed, ultrasound records, risk management decisions, counseling and coordination of care, the time spent when billing based on time. Now, for high-risk pregnancies, that documentation is going to have to show the complexity. What was your decision making? The review of diagnostic data and management that's going to support the higher E&M level codes, right? So the biggest change of 2027 is going to be that every prenatal visit should be documented as complete medically necessary E&M encounter. It's no longer going to say patient here for OB visit, fundal high, the weeks, come back in 4 weeks, right?
The
reimbursement is now going to depend on the documentation for that specific visit rather than the global maternity package.
It's that. And I think for folks, do you think that templates are going to become a bigger deal for the clinics? Like, can they, we actually did create some templates that we'll give to folks after the course in July. And so for you guys that are listening, we are doing a deep dive on this. July 7th, we're going to do it live and be able to kind of go over all of these changes. We did create some template draft notes that you guys can use to help work with your EMR vendor and be able to get those in, because I just think it's going to be more important to get those in if you're not used to doing that.
Right. And I think for most practices, they may not be used to doing that now, right? Because it didn't matter if that template was detailed enough because everything's going to go on a global code. But coming 2027, your template, I think most practices are going to have to revisit that template with your EMR and say, does it support the documentation that I'm going to need, right? Your assessment, your subjective, objective, your plan, so that we meet all the elements of documentation.
Yeah. Okay. So let's talk about 99214. So I got a patient, their prenatal visit. What are the things I need to document from a 99214's perspective? Or do you think, are all pregnancies going to be 992 or prenatal visits 99214 and 5? Or is there going to be a difference between whether or not they can qualify for a 99213 versus a 99214?
I think there's going to be a difference. And a lot of that difference may come with the complexity of the visit, right? So first of all, ACOG has stated that pregnancy should be considered a chronic condition with ongoing monitoring and potential progression when applying to E&M guidelines. So as everyone knows, we also have the data and the risk elements when coding, and we need two of those three elements when selecting the code. For pregnancy, most of the time, the complexity is often already in the clinical work. The documentation is simply going to have to demonstrate that work, right? So to support the 99214, your note should reflect ongoing management of the pregnancy as a medical condition, review and interpretation of clinical data, medical decision based on those findings, moderate risk management, such as prescription medication management, monitoring a condition that could worsen without intervention. So are you monitoring the patient's blood pressure? Are you refilling that blood pressure medication? Is the patient diabetic? Are you managing that? It's all going to have to be within your documentation. Again, it's going to have to support that you did the work versus what we're probably doing now, right? Hypertension, return in 4 weeks, right? Now you're going to have to expand that note to be able to support that you're managing this. This is a moderate visit.
Mm-hmm. So it's not just, hey, labs were reviewed, they were normal. It's like, what labs did you review? What were the results? What did you do about any of them that were not normal? Did you do a prescription? Did you do counseling? Because all of that can contribute to being able to take it from a 99214 to possibly a 99215. But you have to tell the story, it sounds like.
You have to tell a story, right? Especially when reviewing, like your 20-week prenatal visit, right? And you review your anatomy scan, right? So currently, you would say anatomy scan reviewed, patient doing well, return in 4 weeks, right? Under the new guidelines, that would not support, a 99214. It would be a low-level E&M, right? What the provider should be doing now is that the note should demonstrate the data that was reviewed and interpreted to the patient, assessment of the symptoms, if any, clinical decision-making, the ongoing management of the pregnancy, and whether counseling was done to this patient, right? So discuss thoroughly what the findings were, what the recommendations were. Is there any follow-up with a maternal-fetal medicine, et cetera? So, again, currently we're just doing anatomy scan reviewed, return in 4 weeks, but you're not thoroughly documenting whether there was any problems with the scan, whether there was any, it's very short documentation. Maybe those findings were within the ultrasound report, but not in the prenatal flow sheet itself, right? So moving forward, because all those visits will be billable, is we have to go into documentation.
Yeah. And it's not just, again, every note has to stand within its own. So even if you addressed them the prior visit, if you don't document that you've addressed it in the next visit, and again, put that level of detail, then that single billable event that stands on its own may not qualify for the same level of visit in a note that was previous but documented well. So, I think it's like it's not just one and done. It is every single time. And of course, they can bring over notes, but
yes.
But you got to be careful doing that and making sure that, you are truly doing what you say you did.
Right. Exactly.
Okay. So for what is your gut? Do you feel like this is a good thing for practices who maybe really have complex patients? Because at least then you're able to tell that story, or is it too early to tell? What's your gut on this?
I do think it's a good thing. It can be, right? So
yeah.
The critical thinking is already happening, right? The doctors are managing these pregnant patients where, again, it's complex. Pregnancy is complex. Providers are caring for high-risk OB patients, and they're making complex medical decisions every day. They review the data, they interpret the results, coordinate care, they manage significant maternal risks, right? The thing is now, again, because this is all in a global package, they're not reporting those visits, right? And the documentation was never designated to capture the level of work for reimbursement because we're not billing these visits currently. So in 2027, the doctors will now be reimbursed for the complexity of work that they're actually performing versus they're not getting that reimbursement now.
Right. Because it was you just got this average for your global rate, and that is what it is. Now, we have seen some of our practices who've started to play with this type of coding and really adding on E&M visits for those complex situations when it warranted a modifier 25 or something, right? We're seeing a little bit of that. So it's almost like they were preemptively knowing that this was coming, really trying to document the complexity of those patients. And so they were kind of ahead of the curve, I would like to say, don't you think?
Yes, definitely. And a way of seeing this is, the complexity already exists, right? The documentation will now need to reflect that. So the change is going to be, you're already doing the work, but now you're going to have to document it to show your work.
Yeah. Okay. So let's talk about what this change means. We kind of just touched on it, but what this change means for practices managing those high risk patients. So hypertension, preterm history, like obviously under the global model, that, wasn't really something that what they got credit for. Do you think that this is like this now they're going to kind of get credit for that complexity that they were already doing? Is that?
Yes, I definitely do. So I feel that under the traditional global OB model, a practice received essentially the same reimbursement for a high complex pregnancy as it did for a routine low risk pregnancy, right? Because they're not separately reporting these visits. Most practices were not.
Yeah.
So the provider was managing gestational diabetes, chronic hypertension, prior preterm birth, fetal growth restriction, multiple gestations, and they're reimbursed the same amount as a patient with the low risk, right? So they're providing the simply routine prenatal care. The global payment remained the same. So now in 2027, the change will be, if I see it this way, is that practices were financially penalized for taking on most medically complex patients, right? So the new E&M model will change that. There will be two opportunities. In my opinion, it will be that complex visits supports higher level E&M codes, right? So if a provider's managing gestational diabetes, hypertension, fetal growth concerns, there is significantly more medical decision-making occurring during those encounters. Those visits may appropriately support a 99214, a 99215 when documented correctly. So there is the opportunity for the provider to be reimbursed for the high complex work that they're performing, right? Versus now you're not billing that and you're going to get paid the same amount. High risk patients are seen more frequently, right? So more visits mean more billable encounters. Instead of all prenatal care being absorbed into one global single payment, the providers will now be reimbursed for the actual work that they're performing during the pregnancy. So, they're seeing 10 OB visits now versus 17, you're getting reimbursed the same global, right? The same global payment, and you're not getting paid. So now with this high risk patients, if you're having to see them more frequent and the complexity is there, the documentation is there, that's a billable event.
Right. So in that same regard, let's talk a little bit about 99215s then on what they need in order to hit that 99215. Because I could see a practice like, yay, they're getting the credit. They're seeing the complex patients. They can get paid for it. But again, if they mess this note up, 5 times per pregnancy and don't get that credit for the 99215 times all their OBs, like financially, that could be a hit. So talk to me about 99215.
So 99215 represents high complexity medical decision making. The documentation will have to demonstrate a severe or significantly progressing condition. So that condition has to be noted as severe. There's a risk for, fetal death, complications, etc. Extensive data review and interpretation, high-risk management decisions, potential risk to maternal or fetal health. OB examples that may support this level of complexity will include preeclampsia with worsening symptoms, insulin-managed gestational diabetes, severe fetal growth, decreased fetal movement that requires urgent evaluation, cervical shortening, history of preterm labor, hypertension that requires medication adjustments, and close surveillance, right? So those are all high level complexity care. But again, you will have to document all the elements.
You have to tell the story because I think it's not just the quick notes, the quick sentence. It's the full evaluation and management.
Right. I think right now in the current prenatal flow sheet, you may see blood sugars reviewed, continue insulin, return in 1 week, right? This provider may have spent the time, may have performed high-level medical decision-making, but the note didn't need to demonstrate it at the current time, right? So moving forward, that note will have to thoroughly demonstrate, reviewed 1 week glucose log demonstrating persistent fasting elevations. It's going to have to show a clear identified complicated diagnosis, independent review and interpretation of clinical data, prescription medical management, the assessment of the maternal and fetal risk, the ongoing monitoring, and the coordination of care and the treatment planning. So you're already doing the work. It just needs to be documented.
Yeah. And I think that's where these templates are going to be in handy because you can, add notes. You can just remind you, okay, yeah, I've got to add that detail. I've got to add that detail is going to be really key. All right, let's talk same day procedures and modifier 25. So what changes here when it comes to prenatal visits, like an NST or an ultrasound?
So if a patient comes in for an NST, an amnio, ultrasound, the difference is that visit is no longer bundled, right? Most of the time, the patients will have questions if the NST was non-reactive, if there was some type of malformation in an ultrasound. You do the work, meaning you do the consultation with the patient, but again, it's bundled in your global prenatal care. So moving forward to report both of these services, you will have to append your modifier 25 on your code, just as you would, with any other procedure. And the documentation is critical, right? The medical record will have to support that this is a true service. This is including an assessment, a medical decision-making, and management of the pregnancy. A procedure alone is not sufficient to support an E&M service, right? The patient came in for an NST, and will return in 4 weeks. No, you're going to have to document what was separately discussed with the patient that will support your E&M visit, right? Did anything else come up besides the NST? Was there an abnormal finding that you spent 25 minutes discussing with the patient? Did the patient have any symptoms of a UTI during that visit that you will report that in a separate E&M? Did you write a prescription? You will have to report that separately, and then you will be reimbursed for your E&M visit. But, simple, yes, a straightforward NST, may not support
they're just
that
there.
level.
They're just there
You're
for the
just there.
NST. Like that'll
Right.
still be the
Yeah.
procedure.
Again, it just depends. Is she there for her OB visit and her NST? Then yes, the documentation will have to support. This is a separate service, separate reimbursement.
Just like we've been doing with modifier 25s with in different settings, right outside of the prenatal visits. But just like you have a modifier 25 and you have an E&M, you have to be able to separately. It has to be separate and significantly identifiable in order to have that E&M stand on its own compared to whatever else you're billing alongside of it.
Right. Yeah, and I think in pregnancy, there's so many scenarios that can come up, right? Like I can come in for an ultrasound and say, I've had this sinus infection for 3 weeks, right? Or I've had this UTI symptoms.
Right.
I've, anything else that may be related, unrelated. Again, the nice part now is you can report that without risking that visit being somehow coming up in your global service later and you're being punished because you billed this E&M visit during this encounter, right? So
yeah,
the opportunity is there, and I just think we need to get ready for those changes. And I do feel that it will be positive for the providers.
I guess this is our third episode on this topic. I don't want folks to be overwhelmed by what's happening. I think that obviously for the listeners, you guys do E&Ms. This isn't earth-shattering news. It's just now we're having to document like you do in a, problem visit like you do for prenatals. So that's just the biggest thing is for you guys just to really start having the conversations with your practice. Have the conversations with your providers, your physicians, your mid-levels. What is this going to look like in January? And if it were me and this were my practice, I would first look at an audit. So I would pull some random prenatal notes and I would think through, okay, what are the things that people are documenting today? And then how does that compare to visits? If you know that the notes are short and sweet, like you probably could skip that exercise. But then the question is going to be, okay, now I need to build the templates. I need to build out what is the expectation. And if I were the owner of a practice, like I'd be having those physicians and mid-levels, everybody be documenting that way for the rest of the year, because I still don't think we know, and Amy and I touched on this last time, like I still don't think we really know what to do with people who are pregnant now or pregnant, this fall, but aren't delivering to next year, because we're not going to be able to bill for it now because they won't have the codes ready. So I guess we still don't know the answer to this. I think Amy was going to submit a question to.
Right. Yeah, we have some ideas, but we don't know the answer to it yet.
Yeah, that's I think that is my biggest thing to help try and get an answer for folks. And again, I don't know if we'll be able to, but I think that that's the key, is just figuring out, like, do folks just count those OB visits for now, which I think is what we're telling practices right now. It's just, but to document as if it was an E&M, just in case we have to go back and then bill those E&Ms, right? So they need to be documenting that for those pregnancies, even though it hasn't started for next year, right?
Right.
Yeah. Okay.
Yeah.
And then last, as you guys know, we're doing a course in July on this. I think it's July 7th, 4 p.m. Eastern. We will have the link in the show notes so that you guys can register. Even if you can't attend live, come. If you sign up, then you will get the recording, as well as we're going to be doing some template notes for you guys, as well as a worksheet that you can help model out. And I'm doing a whole podcast on this modeling and financial review of like how to think through how many patients do I see, how many times do I see a patient? What is my global rate today? What is my E&M rate today? Like, how can I model out and make sure that my revenue is not going to decrease in 2027? Because I think that that's going to be the question on your mind, is how is this going to hit? My hope is that you get the same amount, or that you hit a roughly what you're getting today for a global fee. But I think it's important to go through the exercise. So check that. We'll do that podcast next week. So check it out. So first, just want to say thank you to Maria. Really appreciate you being on and just being such a great person to work with every day. So
thank you for having me here.
Thank you. I appreciate it.
We have 6 months to get ready, so there's enough time. If I could just say, audit your documentation, update your templates, train your providers so that everyone is ready come 2027.
All right, good plan. Thanks, guys. We'll talk to you next episode.
Thank you, Heather.